A woman's breast is at once the origin of beauty and intimacy, provider of nourishment, and then after all this, it can become a source for individual suffering. This time, On Call discusses breast cancer. The doctors are on call tonight.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
There's the valve.
All of them together.
And which was healthier, the yogurt and the bagel?
All right, I'm going to start by measuring the size of it.
You could also add grilled chicken to this recipe.
Blow hard, blow, 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 keep pushing.
Just your head.
Pull red handle to open bag.
Breast cancer affects 1 in 8 women, and it kills more women in the U.S. than any cancer except lung cancer. This topic, which affects everyone, if not directly then by affecting a relative or a friend, and add to that the threat of breast cancer that hangs over the head of every single woman, is something we need to talk about. There are many epidemiological issues that circle around this topic, some of them controversial. For example, what factors increase the risk for breast cancer? Why are the experts arguing about when mammograms should begin and how often? What other tests for breasts are there, and when should they be ordered? Are too many breast biopsies being accomplished, and what are the emotional and financial costs to our society? But what may be more important is to ask, what are the emotional and financial costs to the individual? There are personal questions that individuals need to ask themselves. Should each woman self-examine her own breasts? And if so, at what age? And how should it be done? Does a yearly clinic exam help discover cancer early? If a woman discovers a lump, what should she do then? What could happen if she ignores a lump for months? There are more questions about types of cancer, how they should be treated, how the treatment has changed over the last few years, and about breast implants after cancer and more. Our job tonight is to answer your questions. We are on call to respond to your needs, and in fact, we depend on them to fulfill the mission of this show. Please pick up that phone and call right now with your experience, your problem, your question. We don't need to know who you are, respecting your privacy, but we would like to know where you're from so we can learn from where our messages are being heard. We invite you at home to call any and all questions concerning breast cancer. Our phone number is 1-888-376-6225. Again, that number is 1-888-376-6225. Here ready and prepared to answer those questions are two recognized specialists in the field of breast cancer. Dr. Amy Krie, oncology internist of Avera Medical Group, Oncology and Hematology, Sioux Falls, and Dr. Julie Reiland, breast surgeon, also of the Avera Medical Group, involved with comprehensive breast care. Thank you both for joining us.
Thanks for having us.
So we'll talk with Dr. Krie first. Tell us a little bit about who you are and where you're from and what got you here.
That's a big question. Do I get the whole lot? No. I'm Dr. Krie. I'm actually a medical oncologist. So I did training in internal medicine and then went ahead and specialized in oncology and always had an interest in breast cancer. So when I came to Sioux Falls 5 years ago to start my practice, I ended up just actually focusing on breast cancer. And here I am, met Julie. We work together all the time now, and it's just a fabulous partnership.
So Julie, you're not just a breast surgeon, or you didn't train in just breast, or
No,
just
no. I am a trained general surgeon, and
Right.
I finished residency 12 years ago. Came to Sioux Falls and did general surgery. But over the years, more and more and more of my patients were breast patients, and I just found that I loved the work, and I loved my patients, and I just so much loved it that I decided I didn't want to do anything else. And
there was enough work in that.
Oh my
regard.
gosh!
Yeah,
And
we're
it's
plenty busy.
And it's fascinating, fascinating work, and it's never the same every day. Every day is different, and we're doing the same thing, but we're doing it differently. Every patient is completely different than the one before, and it's really exciting. And they keep coming up with new things to do and new ways to treat it, and so it's fascinating work.
Yeah.
I love it.
You know, I kind of went through my own list of questions there. You heard those rattled off at the beginning, and I didn't want to put either one of you on the spot.
Go for it.
But we're going to try to respond to patients' questions first.
Sure.
I have one question. Is it indicated to take out the adrenal glands if your breast cancer has spread? Adrenal glands removal if there's spread of breast cancer.
Yeah. So I guess I can take
Yeah,
that one.
please.
That's kind of my area.
Please.
So the most breast cancers are hormonally driven, and there certainly are some hormones that come from the adrenal glands, but the hormones that we think about driving breast cancers are actually the ovaries. So the ovaries produce estrogens, and about 2/3 of all breast cancers then feed off that estrogen. So in a young woman, if her breast cancer has spread into the body, there are times where I have removed the ovaries to help as part of her treatment, but probably not the adrenal glands. We don't typically remove those.
Have you ever heard of any research protocol? Because some estrogen comes from the adrenal gland.
Right. The problem is in removing the adrenal glands, there's cortisol and so many other hormones that have to be supplemented, important hormones. So I have never heard of or seen or done an adrenalectomy for this.
And as a general surgeon, adrenalectomies are very uncommon
Right.
to begin with.
Right.
So if that were a common practice for breast surgery, we would have been doing it for a while.
Well, and I'd also say this, as an old doctor who's been around for a while, when there is adrenalectomy or adrenalectomy, oftentimes, many times there's complications
Yes.
because it is such a complicated, difficult place to get to.
The nice thing is now we have pills called aromatase inhibitors that actually block the hormones that are coming from the adrenal gland in postmenopausal women. So they
Right,
have a
and
pill option for that now.
So let's say that I'm a woman with ovaries and I'm postmenopausal and I have breast cancer that is sensitive to hormonal manipulation. You don't need to take out my ovaries.
No.
You can block it with a drug.
If you're postmenopausal, your ovaries aren't making most of the estrogen anyway.
It's the adrenal
It's
glands.
the adrenal glands and your fat cells. So even if we took out the ovaries and the adrenal glands, your
You're still
fat
making-
cells are still making estrogen.
Fat
So
cells make estrogen?
Fat cells make estrogen.
How about guys' fat cells? Does that make estrogen?
Well, yeah, a little bit.
Fat cells just make,
Little
so if you're a heavier guy, you're going to have some more.
We have higher levels of
Yep.
estrogen in your bloodstream.
Gynecomastia in males tends to happen more often in obese males.
Yeah. Well, there you go.
Yeah.
Well, that's a lesson.
But we have pills
all.
for that. Thankfully, we don't have to rely on the surgeons.
I'm gonna go right to the questions.
for
I
it.
have that one was from Watertown. This is from Madison. Should she go to the doctor? She thinks she has a lump in the breast. Isn't for sure.
That's yours.
That's
Julie.
me. Yes. So whenever a woman comes and they say that they have a lump, first of all, they need a mammogram. And on that mammogram, when they talk to the people about
So you'd
getting,
say bar none, first thing mammogram.
well, when they call my office, we always say, when was your last mammogram? If it's been within 6 months, then we don't need another one. If it's been a couple of years, let's get a mammogram first.
Let's say they're under 50.
Yes, absolutely. If they're under 40 and under 30, I might see them first depending upon what the symptoms of their lump is, because mammograms do have a difficult time penetrating that tissue in the breast when they're very young. And so mammograms may not be very helpful. It's really age-based. And it's also what has been happening in the past. If they had one in the past, we can at least look at it. And if it's been a couple of years, and if they're between the ages of 40 and up, definitely I'll want a mammogram first. When they go get their mammogram, they need to say, I have a lump. A marker will be placed on their breast where that lump is, so that the radiologist, when they look at the mammogram, is at least tipped off. There's a problem here. If they don't find anything with the mammogram, then they'll do an ultrasound at that same time. So that's perfect. Now we all know what we're looking at. If they don't find anything, then I need to see that patient. If they do find something, I need to see that patient. But I like to see them after I've had some of those diagnostic studies, because if I'm going to do anything, having all that stuff in front of me helps me to know what my level of concern is.
Well, they've already gone through certain levels to get to you.
Yeah.
My response, not to counter what you've said, but I'm a generalist. I'm the primary care guy.
Yeah.
They come to me, and then I'm the one who refers them on to you. So I think there's been a lack of hands-on physical exam, listening to the history to start with. I know that people come to the emergency room and they get the CAT scan of the brain before they've even been touched, and to be. So I had a gut reaction there, so I had to express it. It's not that it isn't exactly right what you're doing, but I do think that somewhere along the line, these people need to be examined.
And that's what I do. But see, my thing is that I use a three-prong approach. I look at the mammogram myself. I look at the ultrasound myself, and I examine the patient myself. When all three of those things are not suspicious, then I say to that patient, I don't think you have anything bad, but I'm going to see you back in 3 months just in case. If the mammogram and the ultrasound are fine, but my exam says something's wrong here, I'm going to do another test, or I'm going to do a biopsy. Because I'm with you. If all else fails, examine the patient. You know, I think that's so important, and that's what a breast surgeon does. So what I tell those women when they have a lump and they're being told, don't worry about it, just call. Because we understand that that's an important part. To me, a physical exam by somebody who knows what they're looking and feeling for is essential for breast lumps.
Okay. Any response? That's good.
I think that's good. But women should trust their intuition, because I've seen plenty of women who have had a lump today, really felt like everybody had told her it was okay. Well, it's cancer. So, you know, women should really stick with it.
Be your own advocate, definitely.
And get into their primary care doctor, get that breast exam.
Get that breast exam.
Don't just rely on the imaging.
And if you're uncomfortable with the answer that you have there, then there's another place you can go. Fortunately, people can always call primarily right to you.
Absolutely.
But I really do recommend the idea of starting with your primary care doctor. She or he should be your advocate, should be your home to start with. So your worst fear comes true. You receive a diagnosis of breast cancer. What kind of things go through your mind? What choices do you have? What do you do next? Here's one cancer survivor's story.
In 1998, I was getting dressed for work one day, and I noted that I had nipple discharge. I was seen by my local nurse practitioner and then referred on for a surgical consult. The biopsy did reveal a breast cancer. At the time, we met with the surgeon, my husband and I met with the surgeon to discuss the different options available in 1998 for breast cancer surgery. Because I had just completed the nurse practitioner course, I did realize the option of reconstruction. I chose to have my surgery and have expanders placed, or to begin reconstruction right at the time of the initial mastectomy that was done. I was told that I had an intraductal carcinoma, and the surgeon told us that oftentimes that is what they call multifocal, so you can actually have more than one cancer in the breast. The cancer was not noted on the initial mammogram. He really recommended that I have a simple mastectomy. As you can imagine, I was really frightened. I had 3 children. I had an 8th grade daughter, a son that was a freshman in college, and a daughter that was also in a vo-tech school. You never expect cancer to happen to you. And even though I was medically trained, whenever anyone tells you you have cancer, the fear of death automatically comes to mind. At the time of the pathology reports, they did find I had a second breast cancer, which would have most probably been missed by a lumpectomy. That was a surgical option at that point. The actual chemotherapy was 4 cycles, 1 time a month, following the initial surgery and a length of time to allow the surgical healing. I think the hardest part is to coming to terms with your immortality. It was never about losing the breast. It was about losing my life and not being there for my children. It makes you value your health as one of the most important things in your life and not to place value on material things. It also makes you value the importance of your friends and family. I always tell women if they have concerns about a breast change and their mammograms and ultrasounds are negative, to return to the clinic with additional concerns of change.
Sheri had her mastectomy in 1998. Can I ask the two of you, what are the biggest differences in treatment that we have from 98 to now?
Mm-hmm. I guess I can answer from an oncology perspective. Between 1998 and now, we're doing a lot of actually what we call genomics, and so we're genetically testing these cancers. We know that not all breast cancers are alike. And in doing this testing, we're able to identify how do I best treat this cancer? What kind of treatment does this patient need? Does she just need anti-estrogen pills, or does she really need the chemotherapy? And in doing that, we're actually doing a lot less chemo than we were in 1998.
Oh, really?
Mm-hmm. Mm-hmm.
So that's a good thing.
It's a good thing. It's a good thing.
And surgically?
Oh, well, surgically for me, I know I do a lot of oncoplasty, where I remove for a breast conservation when we're doing a lumpectomy. I remove the cancer and then I reshape the breast so that when we're done, you don't have that divot, you don't have that lump and that scarring that's so typical and the deformity that occurs. The radiation is changing. We have the 5-day radiation course, which is around and it has been getting beat up in the news lately. We also at Avera have a 1-day course where you get the radiation and then that's followed with 3 weeks of radiation rather than 6 weeks. And we're looking at, can we do that radiation in just 1 day? So at the time of surgery, you have the breast cancer removed, you have your radiation, you get your breast lift, and you're done. That's completely.
It's a lot different than in 98.
Well,
Very much so.
What I've seen from Julie is she is able to take, I think, bigger cancers that a lot of surgeons who weren't breast trained, who don't do this oncoplastics thing, would just take to mastectomy because there's no way to get around these.
It's a big lump.
With oncoplasty and what Julie's doing and a lot of the new techniques that we're doing at Avera, we can take these larger cancers but still get them to lumpectomies. And that's nice because a lot of women want that.
I know that in South Dakota there's probably a significant amount of mastectomies that are still occurring.
Yes.
Is that appropriate, or do you have an opinion about that, Juliann?
I have a very strong opinion about that. We've been doing lumpectomies with radiation for 40 years. We've been doing mastectomies for centuries. We have, without a doubt, proven many, many, many times over that when you look at survival, are you going to live? There's no difference between a woman who gets a mastectomy and a woman who has lumpectomy with radiation. There's no survival advantage in removing your breast. It won't make you live longer. So what I'm struggling with is I'm telling this to my patients who are saying, oh my gosh, because they all say, whenever I was younger and I thought I was going to get breast cancer, my first thought was, I'm going to take it off. Now I'm listening to what you're telling me and I'm thinking, that choice isn't so simple. Then they come back and they say, I've had an intervention in my hometown. All my lady friends took me to breakfast and they said, you have to have a mastectomy because otherwise you're going to die. So the general population thinks that this is not real, but we know and we've proven many, many times. And so there's this culture in South Dakota where if you don't have a mastectomy, you're doomed.
I think a lot of the thought is, too, if I remove the breast, there's nowhere for the cancer to come back, so it won't come back. We're less worried about that than we are preventing the breast cancer from spreading into the other organs of the body. And so some people will come who've had a mastectomy and they go, well, I don't need any more treatment because
I just had a mastectomy. I don't need
it's all gone. It's all gone.
Gone.
It can't come back. And so what Julie and I try to emphasize with people is whether Dr. Krie tells you need chemo or pills for 5 years has nothing to do with what breast surgery you choose. Those are two separate things.
So I'm an old guy, and I was here when we finally said, we think lumpectomy and radiation is as good. Well, or lumpectomy alone, or radiation alone. And they were comparing them while I'm reading the literature down at Staley's Cafe on Main Street at Brookings, starting up my practice. And then I remember they went, ha ha, we've proven it. And we all went, yeah, that's one study. I need to see more. These are my family. These are my, these
absolutely.
And so through the years, it's become more and more proven.
Yes.
And we're there.
Yes.
It's time.
Yes.
And so I think people need to stop pushing for mastectomies and go to the expert and say, tell me what I need to do. I trust you, and you don't need to remove it. What are my options?
Well, you know, I've been doing this for 12 years, and I don't want my patients to have to come back with another breast cancer. If I saw a lot of recurrences, I would be recommending mastectomy for everybody. I don't want them to have to go through this. And yet, in my practice, I have seen so few recurrences that I just have to say, and I watch my patients for 5 years. So it's not like they never come back because they went to somebody else. They're coming back to me, and I see every single year how they're doing so well with their lumpectomy and radiation.
No, so I'm going to march into another question, and I'm going to get back to these. I will get back to these questions. But reconstruction surgery, so people can have breasts again, you know, the implants and so on and so forth. What's your take on that? Do you do that after they've had the lumps and the radiation, lumps removed and the radiation surgery? When is
There's
that
been
occurring?
a real push in the past 5 years to do reconstruction right at the time of mastectomy. And so we will put a tissue expander. Usually that's the most common thing, where we make that mound underneath the muscle, and we put what's called a tissue expander, like a balloon, and we fill that with fluid, and then that pushes the muscle out and creates that lump that looks like a breast. We have some phenomenal plastic surgeons in Sioux Falls that are doing just wonderful things with reconstruction, all the way down to reconstructing nipples, and then we tattoo them. So now we have real tissue that looks like a nipple and then has been tattooed to have the coloring of a nipple. I've got pictures of women that patients are saying, those aren't real, because they look so remarkably real. We're also doing nipple-sparing mastectomies and areolar-sparing mastectomies, so we are saving everybody's skin. There's no reason, the cancer doesn't go to the skin, there's no reason to take all that skin off. So now we're able to save much more, making reconstruction so much easier.
Great. All right, next question. 49-year-old woman called, said, can I get breast cancer? Who is susceptible? And who are the, everyone. Let's say you had no family history, you have no risk factors, we should talk about those. Nothing's wrong. I mean, you're perfectly clean bill of health. Are you at risk for breast cancer?
So the first thing to understand is that 75% of the women we see have no family history. So even though you don't have a family history of breast cancer, that doesn't mean you don't get mammograms. And the other thing,
and it doesn't mean you don't get cancer of the breast.
Right. Correct. And the other thing is, 49, that the average age of breast cancer, I think, falls right about 61. So half of the patients are younger than that, half of the patients are older than that.
So
and we see half of the patients are under 61. Half of the half are over 61. So we see patients in their 30s.
Yeah,
I've got
29.
I've got a 26-year-old. So at 49, it's something you need to think about.
More as you get older, higher risk as you get older, but you sure can get cancer.
Yep.
What about the risk factors? What are the major risk factors that are changeable and not changeable? Let's start with non-changeable. Your parents. Can't change who your parents are.
That's correct. 10% of women who get breast cancer inherit a gene that predisposes them to breast cancer. But 75% of women who get breast cancer don't have that gene. Now, you can inherit that gene from either your mother or your father. It's equal distribution, so it doesn't matter. So if you've got a family history where grandma had it, my mom had it, her sister had it, my mom's sister's daughter had it, those are very significant family histories, and those are people we want to know about, and we would put them in high-risk clinic. We would actually look at their genetics, maybe test them for a genetic defect that predisposes them to breast cancer.
And the same go with if your father's mother, sister, grandmother.
It doesn't matter.
It's both equal from both sides.
It's a little bit difficult when you have grandma on dad's side and aunt on mom's side. They don't add together. So they have to be that whole family on one side.
And is it a recessive or a dominant genetic thing?
The BRCA is dominant.
Okay.
Yeah. So if you inherited it, then there's a 50-50 chance that your offspring, 50-50 chance that your brothers or sisters have it.
In other words, we don't even want to go there.
Yeah.
So other factors.
So one that I'm looking at right now is obesity, and it's predominantly obesity in women who are postmenopausal. So when we look at what women weighed when they were 18 and what they weighed when they hit menopause, if there's been significant weight gain and significant obesity, they're at quite a bit higher risk for developing breast cancer.
50% higher.
Yep. So, you know, one of the things we're targeting not only in the high risk group, but in our own breast cancer survivors is really watching obesity. And it's a couple things. The fat cells probably make estrogen. And the other thing is that the fat cells probably increase their insulin levels, and insulin contributes to inflammation, and it's just an easy place for cancer to sort of set up. So obesity is one that a woman can change and that we're really targeting.
It increases estrogen levels.
Right.
Mm-hmm.
So, and then what else is there? Is there the earlier they have their menstrual cycles?
I mean, there's a lot of things that you can't change. So,
That's
you know, when you
it.
started having your periods, when you went into menopause, unfortunately, we don't have control over that.
Early babies. Later babies, does that make a difference?
Don't have a lot of control over that.
And here's the thing. I mean, I have patients in my practice who are thin, who've had 12 children,
who breastfed them all for a year,
yep. And they still got breast cancer. Yep. So to me, those.
But you said breastfeeding does have a tendency to lower your risk of breast cancer.
That's right, but that doesn't mean you have a guarantee of anything.
I think it's a point of pointing out the risk factors, but not placing blame, because people who have zero risk factors can still get breast cancer. So
I've got a bunch of them.
That's definitely there. Hormone use, the combined estrogen and progesterone use.
Yeah, let's touch on that. Estrogen. People are having terrible hot flashes. Oh my gosh, I'm you know, help me. Let me have some estrogen. I need some estrogen. I'm not saying that about me. Of course, I'm a guy. I'm a masculine fella.
But you've
I've
seen us
lived
all.
with people who have had that.
You've lived it.
So the question is, how about estrogen?
Yeah.
How big of a risk?
Yeah.
I mean, it's not as big of a risk as we've been made to think, is it?
So one, it's the combined estrogen and progesterone. So a lot of women, if they've had their uterus out, can just be on estrogen. And there's not as convincing evidence there. But if a woman is on combined estrogen and progesterone, for every 10,000 women, there's going to be 30 extra breast cancers.
For 10,000 women?
10,000, there's going to be 30 extra. So as a society, we see more breast cancers. Now, as an individual woman who's hot flashing in your house, if she needs to go on hormone replacement, just be on it for the least amount of time at the lowest dose to control your symptoms. So what I don't like, and get off of it, you know, reevaluate, because we'll see patients who were put on it 10 years ago, they don't know why they're on it, and nobody bothered to stop it. So
the other thing is that when I have a high risk patient, somebody who's maybe in her 30s and 40s, has lumpy breasts, very dense breast tissue, strong family history, I'm going to tell that woman, listen, when you go through menopause, if you can get through without hormone replacement therapy, you shouldn't be on it.
So
you should really try to avoid it. No, that's okay.
So good options of treating the hot flashes, hot flushes, hot whatever they call them, would be Effexor. Yeah. What else?
I like gabapentin. So it's Neurontin. It's a nerve drug, and at a very low dose that has minimal side effects.
Like 100 milligrams?
300 milligrams TID, but usually we start just with 300 to 600 milligrams at bedtime, because it's a little bit sedating, so it helps women sleep, prevents those nighttime wake you up hot flashes. And I have secretaries without breast cancer who take it for hot flashes. So it works pretty well.
You know, then I've got patients who really don't want to take any medication. They say that yoga's helpful. There's been acupuncture. That's been helpful. Exercise program. There are a lot of things you can do. So again, I think you have to assess how bad is it. I've seen women who have debilitating hot flashes. Those are people that really need our help. If you're just a little bit, try to power through.
Now, for a woman who's actually had breast cancer, probably shouldn't be on the estrogen and
at all.
progesterone. So they need to talk to their oncologist about those things.
All right. A fear that many of us have when we go to a physician is that they will tell us that something is wrong. Just the nature of breast cancer and mammograms presents the opportunity of a false positive reading, or having the radiologist see something that isn't obvious whether or not it's cancer. This may mean that the patient needs to go back in for another examination.
When a woman has a mammogram, the radiologist will usually send a report to me as her primary care physician, and that report will have one of several categories. Anything from this is a normal report to this is a report that's very suspicious for cancer. Most of the time the reports are normal, and I send off a letter telling a woman that, oh, your mammogram's just fine, nothing to worry about. It's very rare for a mammogram to come back and say this is suspicious, but unfortunately it's not at all uncommon for a mammogram to come back and say, there's something here we need to take another look at. The statistics are that about 10% of mammograms will result in that woman being called back for further testing, some kind of additional imaging study. And the statistics are that 90% of the time it's just fine. There's nothing to worry about. But it's still pretty scary to get that call. Or occasionally they'll recommend we do a biopsy. Even then, most of the time it turns out to be nothing, but they just need that extra step to make sure that it's not cancer, which is the whole reason we do the mammogram in the first place. The statistics say that if you get enough mammograms, your odds are really high, 30 to 50%, that at some point in your lifetime, you're going to get called in and said, hey, we need to do another test, we need to do another follow-up. What I like to tell my patients is, knowledge is power, and when you know it's all okay, you're in a much better position, and if you find out that it's not all okay, then you can move forward and get it taken care of, and you want to find things as early as you can so that you can treat them with your best treatments, your least invasive treatments, your least toxic treatments, and your best chances of success.
So how concerned should a woman be if her physician calls her and says there's something there and we need to take another look?
Well, it depends upon what that is. There's different, as Dr. Johnston said, there were a lot of different levels of what that different look means. Whenever they do a core biopsy or they recommend a biopsy, it's because they see that something's very suspicious and they want to sample that tissue. And that you have a chance that you could have a breast cancer there. They're very good at recognizing those suspicious areas and what's most concerning.
So when they say they need an ultrasound, how worried should you be?
I mean, it's important to get it done. I don't know. I guess for me, breast cancer is such a treatable thing. Try not to worry. We're going to take care of it.
It is. I think that's,
I know.
Isn't that reassuring?
I know.
I had a patient who ran from it, and she had a breast cancer, and it grew until it burst forth through the skin, and of course died within the year. And someone out there was treating this with an herbal thing. And she just wouldn't bring herself to come to get help. I can't, it just kills me to think about it. But
what I want to tell my patients is don't panic. We'll take care of it. We'll take care of you. Don't panic. It's going to be okay.
Yeah. And the vast majority of those callbacks are not going to turn out to be cancers.
Just take a deep breath and hang in there.
Come in.
It'll be okay.
Follow in.
Well, you're going to panic no matter what, but tell yourself the vast majority of these don't turn out to actually be anything.
And if they are, they're very, very
treatable.
Small and very treatable.
We have a bunch of questions. Been mammogrammed, she said, seen by the doctor, told it doesn't need to be removed, had it for 10 years, a lump above the breast, encapsulated fat. Is it okay to leave it?
Yeah, absolutely. I would. Especially if it's been there for 10 years and it hasn't grown. There's nothing wrong with it.
A man from Sioux Falls said comment on the instances of breast cancer in men.
Yeah, so men account for about 1% of breast cancers. The important thing, we treat men very similar to how we treat women with breast cancer. They can have estrogen-driven breast cancers and hormone-driven breast cancers just like women. The important thing to know for male breast cancer is that, Julie talked about the gene that you can inherit. If there's a male breast cancer, that's a big red flag to us that there might be some genetic stuff involved, and they should see a geneticist.
Oh.
Yeah.
Or should be tested.
Or should be tested.
If I have a male breast
gene.
cancer patient, I will test him.
Automatically.
But okay, so you've tested me. Okay, I've got it. So what are you going to do there?
Well, we know that you have to have a mastectomy because we don't do lumpectomies on men.
Right.
Okay, so the men get some.
Probably more importantly, the men have
What are we going to
daughters
do
and
with their
sisters.
family? See, then we
There
can
you go.
test the whole family. We can do all the relatives on that side of the family.
But a mastectomy in a man means?
That we remove the nipple areolar complex, that pigmented part in the nipple, and make an incision. A lot of them who have hair on their chest, it grows over and they can't tell. I mean, it's very nice. It's not nearly as debilitating or deforming as it
So
would be
you take
for
the
a
nipple
woman.
and all the glandular tissue underneath. But you don't need to take the muscle.
Absolutely not.
Now I remember.
That's very old.
Remember the.
That old. He's saying, I
I'm
remember.
an old guy. Boy, there were a lot of people.
I've-
And the lymph
Oh, yeah.
drainage problems. Boy.
It's just not a problem as much these days.
So a woman from Brookings said, what do you think about women taking aromatase inhibitors for life to prevent breast cancer? Tell me what an aromatase inhibitor is.
So an aromatase inhibitor is exactly what we were talking about before. It's preventing the production of estrogen from the fat cells in the adrenal glands. And so it's effective only in postmenopausal women. You have to be postmenopausal. And there was a recent study in women who were quote-unquote high risk for developing breast cancer that showed that the aromatase inhibitors had a 60% decrease in the chance of developing breast cancer. So we should all be on them, except for the fact that they do have side effects. So
Like
joint aching, decrease in your bone mineral density, vaginal dryness.
Loss of sex interest.
Goes with the vaginal dryness, yep. So they're not without side effects. But again, a high-risk woman, this is something we talk about in the high-risk clinics, is there's tamoxifen, there's aromatase inhibitors, and for women who have a 30% lifetime risk of getting breast cancer, these are things we consider.
Is tamoxifen an aromatase inhibitor?
Tamoxifen actually blocks the receptor right on the breast cancer, so there's still some estrogen around. It just blocks where it's working, so to speak. So
But
a little less on the side effects.
It does something about the bones, though.
Tamoxifen actually builds bone
Right.
density. So for a woman who's got brittle bones, we might use the tamoxifen instead of the aromatase inhibitor for prevention. So those are big discussions.
Again, tailored to that person.
So, you know, I have to say, in your field, you tailor it to the individual. My whole life is tailoring everything I do to every individual. I mean, that's what medicine really is all about.
That's
isn't
the
it?
fun
So you're looking at the bone density,
Yeah.
how high is their risk of getting breast cancer, the side effects of the medications, and just talking it through with the
What's
patient.
happening at home, how their emotional status is, the real human being. Wrap that around the cancer. That's an important issue. A female from Alpena said, had breast cancer in '96 and went through 18 treatments of chemo and 18 of radiation. Then she came to South Dakota, was given a genetic test for cancer, didn't have the gene, wonders why she still needs mammograms. Interesting story.
Well, she still has breast tissue, I take it.
I think so.
I'm expecting that that's the case. If 96 must have had a lumpectomy.
Yes.
Okay. You know, anytime breast cancer can come back. If you made it once, your chances of making it again are actually higher than somebody who's never made it.
With the residual breast tissue that you have.
Yes.
Now, if you've had a
on the other side.
mastectomy, you just need a chest wall exam, not mammograms.
Right. So, and that's another thing is that I follow even my patients who've had mastectomies. I keep an eye on them for 5 years just to make sure, because breast cancer can regrow under the skin. There's a 3% lifetime risk.
Yeah.
But if you have a bad breast cancer that's just really badly behaved, it could do that.
So what I think she's saying is she had the genetic test on it was negative. So, you know, if she had the BRCA gene, the breast cancer gene, her risk of getting a second breast cancer in 5 years would have been 25%. So we would have followed her with maybe MRIs or offered prophylactic surgeries. So she still could get a recurrence, it's just less likely. So
now, I'm an old guy, and I'm not on the cutting edge of this. You guys are. I lean on you. So there used to be that if a certain kind of breast cancer was discovered, you know, a ductal kind of thing, in one side, almost always they got it on the other side.
That was lobular.
That's it. Explain that.
Oh man, we have gone all from one end of the spectrum to the other with lobular carcinoma in situ. Lobular carcinoma in situ used to be something that was considered a very worrisome cancer, and women who got LCIS, when they got it on one breast, lobular carcinoma, which is not even invasive. It's just in the ducts or in the lobules. Okay, so it's
tiny little early. It's like now we're talking polyp of the colon that you can remove.
Exactly, similar to that. So what we find is that women with LCIS, we consider them now to be at high risk for developing a breast cancer in their future, and we put them in high risk where we keep an eye on them. We used to offer them bilateral mastectomies. We no longer do that. So now they come in and they see us every 6 months, and we keep a close eye on them. We might offer them an aromatase inhibitor or tamoxifen to decrease their risks. We'll watch them much closer.
Do you do do the genetics?
Depends on
it depends upon everything else.
All right. Wow. All right. Well, when a woman is diagnosed with breast cancer, it brings in an army of physicians, nurses, and other support staff. On the Sioux Falls Avera campus, there is a weekly conference that brings all of these people together. Every Wednesday morning at 7 o'clock, they meet to discuss the best procedures they feel will work for each and every new breast cancer patient.
Oh, we see cases, we saw this morning, cases of breast cancer that were found early, and sometimes very early, only a few millimeters, on screening mammograms. A woman comes in, we find the breast cancer, we find it before it's metastasized, before it's going to end her life, when it's easily treated, and we find it on a regular basis. And nationally, internationally as well, it's been proven over and over again that breast screening with mammograms, physical exam, do catch cancers earlier, and there's greater than 30% reduction in mortality from breast cancer with screening mammogram. It's been approximately meeting 2 years, and basically it is the pathologists, the radiologists, plastic surgeons, breast surgeons, radiation oncology, medical oncology, as well as a number of support services, nurses, and technologists that all meet and discuss every new case of breast cancer that comes to the Avera campus. One of the main purposes of the meeting, determining what kind of operation is going to be most effective for the person, for the woman involved, and also least invasive. For example, if a woman is eligible for a lumpectomy and it is in her best interest, we would definitely urge her to have the lumpectomy and have a small portion of her breast removed rather than having a mastectomy and the entire breast removed, especially when we know that long-term outcome and survival will be the same. We want to preserve the woman as much as possible. And it depends on what the woman wants. And so that's the other thing. The women aren't present at the meeting, but the women have met with different physicians and expressed concerns or expressed what their desires for treatment are, and then that is taken into account. We had 12 cases of breast cancer, very different presentations and different choices as far as, especially now, there's all different choices with different kinds of radiation, different methods of delivery of radiation, different kinds of chemotherapy, as well as different ways in which to evaluate the breast tissue and follow and determine whether or not the cancer has metastasized or not. Deals also with the nature of the disease, with the pathologist evaluating and reevaluating the different kinds of breast cancer that there are, the different receptor hormones that are involved in that breast cancer, which also helps the pathologist, it helps the medical oncologist. The pathologist also helps the surgeon in determining the margin status, meaning if the entire cancer was removed and how much of a margin is there around the cancer to ensure that that cancer will not come back.
So how important is a meeting like this to the treatment of cancer? I mean, I have to say, personal bias, this is wonderful. This is exactly what physicians should be doing. In my mind, this is the height of quality care. It's what began medical schools, and it's a tradition that is so important that we collaborate, that we all collaborate.
I think the fact that it was actually 4 years ago, we started it a year after I had been here, we got it together and started it. And the fact that the physicians continue to show up at 7 a.m., not getting paid, on their own time, it's phenomenal, and it continues to grow.
Everybody stays in their seat.
And this week we were there before 7. We were there at like 6:30.
The doctors like it. And the reason they like it
because it helps.
It helps.
It helps.
I've learned so much. I've learned so much. Now when I see a patient, I can look at those mammograms and I can say, what's Dr. Alpers going to think? And what is she going to want to get? And then I can say, gee, I'm kind of puzzled. I'm going to take this to breast cancer conference and we're going to all talk about it. And then I can anticipate much better now than I could 4 years ago, because I sit there and oh my gosh.
Well, we all knew what we did, but I might not have been thinking, what is Julie thinking when she looks surgically at something? What is the radiation oncologist thinking? What's important to them? So we've gotten better at understanding the whole picture of treatment, and studies have shown that cure rates are actually higher for women whose cases are presented at these sort of conferences.
But it isn't just women at those sort of conferences. In the Brookings Hospital, we have noon conferences twice a week.
Yeah.
We have the same kind of collaboration about different topics. That's what you call class medicine.
It's exciting. It's exciting to sit down with a group of people that know their business really well, and you all get to share ideas.
Mm-hmm. You rub a case, and you rub it over and think about it.
Exactly.
So how do we decide whether? What about mammograms? Are we getting too many mammograms? That's a question that's going on. A lot of people have argued the new mammograms. Is that any better?
Yeah.
Are we doing too many biopsies? Is this driven industry?
I think it's a heated debate, and the debate really boils down to there are some breast cancers that grow so slowly that you could live with them for a long time. They would never cause a woman harm. She may go on to die of something else.
Heart attack.
Right. And then there are some breast cancers that grow so quickly that no matter how early you catch them,
it doesn't matter.
It doesn't matter. They're going to spread anyway. So in order for a test to be effective, it's got to catch a cancer when it's curable and make a difference in that. And yes, there are going to be some slow growers that we probably overdiagnose, and yes, there are going to be a few, but the vast majority of cancers still, if we catch them at an early stage, we know we have higher cure rates. And it's potentially less treatment that woman has to go through. She may be able to get a lumpectomy instead of a mastectomy. She may be able to avoid chemotherapy. So finding it early not only means easier treatment,
it might
but
save
still
money.
higher cure rates.
It might save money. Now, I mean, I don't mean to bring that nasty word.
As national,
It's a national issue.
Yeah.
We need
so we still say get your mammograms every year. Yeah, definitely.
So,
starting at the age of 40.
All right. So, but there are people, and my personal bias is to start at 50, do it every other year, unless there's problems. Mm-hmm. I think there's some debate. Mm-hmm. You guys know better than I do, but I would say this: the National Task Force has said 50 and every other year.
And the American Cancer Society has said yearly and stuck to it. So there's a lot of debate out there, and it's something you just need to have a talk with your personal physician.
Just make sure that you do get that mammogram.
I mean, frankly, 40% of South Dakotans have not had a mammogram in the last 2 years. So to me, whether it's every year or every 2 years, we still have a huge percentage of the population who's not doing it at all. Right. I mean, how many times do we see a patient who hasn't had a mammogram for 10 years? And so we can debate about...
It's just heartbreaking.
I think the answer is 1 year. You may think less, but in the end, we need it to be done at all.
Yeah.
Right.
Watertown, cancer in your lymph nodes. Will radiation take care of it?
Is that
That's
Z11?
a loaded
Is
question.
that Z11? That's really going to depend on the scenario. I think the change that's happened is for women who have 1 to 3 lymph nodes, a small amount of cancer in those lymph nodes, who are going to get either chemo or pills, and who are going to get radiation. There are some instances where we don't need to remove the additional lymph nodes, but that's a case-by-case thing.
Definitely maybe.
Okay. Do we need a mammogram after 80?
If you're in really good health, yes. If your doctor tells you wouldn't tolerate a surgery, it's probably time to stop.
Okay. I have a female, recurring breast cancer, 13 years ago, had cancer, had it again this September this year, got both breasts removed.
Mm-hmm. She needs genetic testing.
Important. How can you get in touch with, Dr. Holm? And the answer is, I can't answer all those questions. And we have
his personal cell phone number is.
That's great. Call the clinic in Brookings. Rapid City, risk factors, moderate. Alcohol consumption affect breast cancer risk?
Yeah, so alcohol consumption increases the amount of estrogen in one's bloodstream, which could potentially increase risk for breast cancer. We say in moderation.
That means more than 2?
It's very clear that more than 2 drinks per day is going to increase risk. Very clear.
And less than 2
So if you like one on occasion, on the weekends, you're just fine.
So we want to, all right. Recently a patient presented with a lump in her breast, and we suspected an infection since her exams had been up to date and the last mammogram was negative. That day her exam was worrisome, however, and a repeat mammogram showed a suspicious area. By the time our workup was done, we found breast cancer that had spread to many lymph nodes and to the bones of her back. But what seemed then like a death knell for my patient turned into bells of celebration as we observed a marvelous reversal of her condition while our cancer specialist, Amy Krie, treated her with modern medicines. I'm thrilled to state that at this time our patient is comfortable, the cancer seems gone, and there is a reasonably good chance that it will not return. Many women have been brought to face with their mortality through malignant diseases of the breast. It seems such a paradox that something as influential to society as the image of a young woman's breast can then become the source of mama's milk, and after that such a potential for human suffering. I was surprised to learn that the human female is the only primate that possesses fully formed breasts even when not pregnant. But it's no surprise that evolutionary psychologists believe breasts are what attracted ancestral mates seeking a healthy partner with whom to make children. Experts also conjecture that it was just that trait of the female breast which encouraged woman-to-man face-to-face interaction. Humans are the only mammals that mate in this manner. Anthropologists suggest that this full frontal interface and communication leads to the formation of the emotional bond required to bring social progress, and thus the search for and expectation of compassion and justice in all arenas of human interaction. Think about it. A woman's breast is at once the origin of intimacy, the nourishing gift of mother's milk, perhaps the foundation for civilization, and then after all this nurturing to become such a potential source for individual suffering. Response, Julia.
Wow. That's pretty significant. You know, I've always thought it's, for my patients who have breast cancer, it's not your fault that our society puts so much emphasis on breasts. You know,
it isn't our fault, is it?
No, it's just how you were raised, and so breasts are a big deal, and so there's a lot of hype about it, and breast cancer, the word breast cancer on magazines sells magazines. And so there's a lot of hysteria, there's a lot of myth out there about breasts because women are so afraid of
and a lot of guilt. Like I drank a glass of wine, so I got breast, you know.
There's all sorts of things. I did this, you know. And so I think we have to realize that breast cancer is a disease that you get, and it's not something that you can do, that you can really, I mean, we can prevent certain things, but that don't be guilty about it. You know, I always tell my patients, you have breast cancer, but it doesn't have you. And so you have control over this, and you have control over how you think about it, and you don't have to be guilty, and you don't have to be a victim. You can actually be in charge of it.
Oh, Amy, your comment to that, I mean, the guilt.
It's out there, and I'll have women come in with, you know, is this because I use deodorant? Is this because I drank out of plastic water bottles? And unfortunately, there's potential lists miles long of what the potential causes of breast cancer can be. But in the end, we're all women, so we're all at risk, and that's what it is. My favorite patient is a lactation consultant. So she spends her whole career helping mothers to nurse and seeing the milk and all this, and got breast cancer. So our theme on her visits is when good breasts go bad. So.
There you go.
It's a T-shirt.
So, take-home message. I mean, okay, we've got each a minute. Summarize. Julie?
Follow your intuition. If you think something's wrong, make sure that somebody looks at you and takes you seriously. Don't panic. If you have a lump, if you have breast cancer, you do not have to have surgery tomorrow. Let us help you get our ducks in a row. Let us help you get you to that breast cancer conference where you have 20 brains looking at your particular case and coming up with the best plan for you. But don't panic.
Yeah, but if your intuition is to say panic.
Get to help. Get to an expert. But then once you get there, trust that they know what they're doing and they're not going to let you fall.
Yeah, find somebody you're comfortable with.
Yeah. A minute for take home.
Let's see. From my standpoint, I still believe that mammograms are very important. I still believe that early detection helps us to need less treatments and to catch these earlier when they're more treatable. So that's still where I think we need to be. And to know that 40% of women in South Dakota don't get mammograms in the last 2 years is just, it shouldn't happen. And when women don't have insurance, that number actually drops to only 38% of the women have had a mammogram in the last 2 years. There's programs like All Women Count that women can sign up for to get free mammograms and free treatment if a cancer is found. And so there's really no excuse, and women just have to do it because a lot of people depend on us to be around.
Self-breast exam?
Mm-hmm. Self-breast awareness is what I like to promote. So if a woman finds a lump, persist on and get that evaluated.
Well, that wraps up our show for this evening. I hope we have provided you with effective information about breast cancer. I sincerely thank my studio guests, Dr. Amy Krie, oncology internist of Avera Medical Group, Oncology and Hematology in Sioux Falls, and Dr. Julie Reiland, breast surgeon, also of the Avera Medical Group, involved with comprehensive breast care. Thank you both. It's been wonderful fun.
Thanks. It was fun.
And that's it for our viewers. Thank you for watching. Your questions and input really do make a difference. Until the next time, stay healthy out there, people.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.